Yeah, I'm glad you brought up the patient that's failed all other modalities, and at what point do we position opioids in our treatment algorithm? And it sounds like it's not first-line therapy, but let's say the patient has failed all treatments so far. Chris, how do you decide on, we have a number of opioid formulations available to us. We have long-acting extended release, we have short-acting immediate release, we even have a relatively new class of rapid onset drugs. What are some of the factors you consider when choosing one of these formulations?
Again, history defines what I would select first. What have they responded well to? What are the prior successes and what are the prior failures and the side effects that they experienced? In addition to that, what is the daily timeline of the pain? Is it something that is sort of constant 24/7 but really varies? It's worse at the end of the day versus in the morning versus at night, for example. Or is it something that is on and off, where, for example, a pain of trigeminal neuralgia, it comes on several times a day, is instant on, and pretty quickly tapers off. So that determines what compound you prescribe and the pharmacokinetics of what you're prescribing. So if it's something constant, daily, ongoing, you can consider a long-acting formulation. Oftentimes, these patients come to us, for example, on Vicodin 3 times a day or Percocet 3 times a day, and that could be milligram per milligram converted to, for example, OxyContin or whatever is suitable. If the pain is sort of very binary, very on and off, they could be treated with ultra-rapid-acting opioids, where you can capture the pain, and the pain is treated when it needs to be treated, but it's not treated at other times. I think for the vast majority of us that is treating non-malignant pain, the pain is constant, daily, and for that I like to emphasize a trend away from the quick-acting or short-acting medications, because for that ongoing daily pain, you really need to provide an extended-release medication. So just like we don't treat hypertension every 4 hours, we don't treat diabetes every 4 hours, and we shouldn't treat constant daily pain every 4 hours.
I think that's a great point. And understanding the temporal nature of pain, clearly it helps you choose your agent. Joe?
Yeah, I think Chris has also, very articulately spoken about using long-acting opioids as that baseline ability to address their constant pain level. And I think we can go even a step further now, and we can look at things like asymmetric dosing. And Chris, maybe you want to talk a little bit about that.
Basically, it depends on the daily pattern of the pain. Let's say pain of postherpetic neuralgia versus osteoarthritis. So osteoarthritic pain, spinal stenosis, and OA of the knees will be worse in the morning and pretty much may build up as the day goes on. So somebody like that could be at a higher dose in the morning and a lower dose at night, whereas somebody with postherpetic pain, neuralgia, may be on a higher dose at night and a lower dose during the day.
Let me stir the pot here a little bit. Vitaly, I was trained 20 years ago that if somebody makes it up to 3 or 4 hydrocodone or oxycodone short-acting tablets a day, they get put on a long-acting analgesic. And I did that for the better part of my career. But I've started to cut back on going right to those long-acting opioids, thinking that, hey, I really need to know about their patterns of pain, almost like Dr. Garibo's talking about. What's your philosophy?
Well, my philosophy is such. First of all, what Chris said as far as the long-acting medications, well, they do provide this baseline control of pain. But as he also mentioned, the patient's pain is not constant throughout the day, especially with patients with musculoskeletal disorders. While I would like to decrease the number of short-acting medications that they take per day, at the same time, I would like to provide them with medications for rescue, for breakthrough pain. And I'm hoping that by providing a long-acting medication as a baseline, their use of short-acting medications will decrease. As far as using short-acting medications at the beginning of our relationship with a patient, I actually use them in a very similar fashion as you would use in acute or semi-acute patient in an inpatient, patient-controlled analgesia, that you would observe the patient for several days, how they use this patient-controlled analgesia when they administer short-acting opioids, and then converting this to a long-acting, a combination with a short-acting. So I might not necessarily, during the first visit, would convert the patient to a long-acting medication, but I would rather, based on the risk assessment, I would liberalize their short-acting medications a little bit, adjusting the dose, and then would bring the patient, let's say, 2 or 4 weeks later. And they will say, look, you have been using, let's say, 6 to 8 pills of a short-acting medication. This is not a great approach. So I will start you on a longer-acting medication and will supplement this with several pills of a short-acting medication.
I think we could probably have a discussion all day long around this particular topic, because then your patients come back and say, hey, I was better on those short-acting pills. I don't want your long-acting preparation. But let me just make a comment, and I'm sure my colleagues won't disagree. You can't assume that patients understand the difference between long-acting and short-acting agents. Many do, but then again, we'll see patients who are put on a 12-hour preparation who come in taking 6 a day, right? So you have to educate patients about that. And while we're on that point,